Welcome to the Wellness Revolution podcast, the radio show all about wellness in your mind, body, spirit, personal growth, sex, and relationships. Stay tuned for weekly interviews featuring guests that have achieved physical, mental, and spiritual health in their lives. If you'd like to have access to our entire back catalog, visit drveronica.com for instant access. And here is your host, Dr. Veronica.
So welcome to another episode of the Wellness Revolution. So today we're going to talk about the big C word. You know that big C word that everybody dreads. If it hasn't affected you, it's affected somebody close to you. Everybody knows someone in their family who has had the big C, and that is cancer. And what's the issue with cancer besides people feel that when they get that diagnosis, they're staring death right in the face, and they are. They have to change. They have to do something different. But what also happens is you who have cancer as the patient, you have no idea what to do and who to turn to for advice, other than you go to the biggest hospital you can find, the doctors that you can find. Your family has nobody that they know to turn to. And there's just a little bit more. It's not just about, should you have surgery? Should you have chemotherapy? Should you have radiation? What about alternative care? Who do you ask these questions? Well, now there is someone that you can ask these questions of, and a book you can read about it. And so I'm bringing that to you today. Well, who better than an oncologist? Now, this gentleman, Dr. Kevin Ryan, is extremely special, not only because he's been an oncologist, but because he's also a decorated retired colonel. So we're going to hear a little bit about that and where he's been in his life and what made him decide to write this book. So he has a book. I want to tell you about it several times during the interview because I want you to go get it. When tumor is the rumor and cancer is the answer. Doctor, oncologist, author, doctor in 3 different medical fields. Oncologist, Dr. Kevin Ryan. Welcome to Dr. Veronica's Wellness Revolution.
Thanks a lot. Appreciate being here.
So much, Dr. Ryan. I really appreciate that you're on and that you've decided to talk to all of us as potential patients, as families of patients about the big C word, because you have seen firsthand what happens to people when they get the diagnosis. You've held their hands. You've helped some of them live. Some of them, unfortunately, have not lived despite your best efforts. And you've laughed with them. You've cried with them. You've done everything in your ability, but then you realize there was some void. So first, before we get into that, you have that beautiful behind you, all these medals. Tell us a little bit about the medals first.
Well, this is called a shadow box, and it's what's given to you when you finally retire. And it is a flag that's been flown over your last facility. And then the larger medals are the various awards that you've been given. I don't have any combat medals. I have tour of duty ribbons, but I was not a gun-toting soldier. But there's the equivalent of like a Silver Star and a Bronze Star and meritorious service medals and joint service, meaning all 3 services recognized what you did, and commendation medals and humanitarian medals and achievement medals and things like that, and longevity and excellence in teaching, and there's a lot. Superior Service, Distinguished Service Award, those types of things. The things that you see on when you see them a lot on generals, brigadier generals, and some colonels will have those in the ribbons, or they'll wear them in their called mess dress, which is their tuxedo-like dress uniform. Looks very nice.
Yes, all three of my sons in high school for a while went to a military academy, and they used to get all these little decorations and award for being on the honor roll and good behavior and just all these type of pieces that they put on their uniform, and things around their neck. And it was exciting because when they made the honor roll or the president's list, as on Mother's Day, we would go and be able to pin the stars on our son's uniform. It was always something that was just very special. So even though they weren't in the formal military, it was a military school with a lot of people who were retired military who were running it. And it was a very special experience, difficult, but gave them discipline and manners that until today, although they're not in that, they know how to treat people. It's interesting because we believe that, you know, you fight, but the people, the men and women who serve in the military seem to, you just meet them and have so much respect for everybody they meet, which is a value of the military that you never think about. So
it's a different culture. Yeah, the pinning aspect is also retained on the active duty side. When you make full bird colonel instead of what we call a telephone colonel, where the phone rings and you're a lieutenant colonel and you answer and say, Colonel Ryan, but you're really just a lieutenant colonel. When you're full bird, that's when you have the wings. You might have seen on various shows or other uniforms. It's an honor if you can have a general give you one of his colonel's wings from his uniform to pass it down. And then if you proceed in rank, you can pass yours down. So some of them are multiple generations long. And I had a Surgeon General gave me his wings. So it's very nice.
Oh, wow. Okay.
And he wrote the part of the endorsement for the book.
Oh, how amazing. So let's switch over to your medical career. So I know that oncologist, internal medicine, hematology, that you're trained in all three of those, but your main career has been as a cancer doctor. And so tell us a little bit about that and what got you into writing this book.
Well, when I was growing up, I was one of those kids that said, I want to be a doctor. We find our way at different points for different reasons. There's no rhyme or reason necessarily, but when I was a little boy, 3, 4, 5 years old, I'm going to be a doctor. And science and dealing with people's emotions and perceiving how people felt were two things that I really cathected to, I really gravitated to. The science, the more and more I went through it, you think of the malignant cell, it's the ultimate, it's Sherlock Holmes, it's the ultimate caper. It's the great mimicker. It's the marauder. It's the masquerader of what is normal. If you can figure out what makes it tick and how did it get away with being alive, then you're figuring out a huge amount about the normal immune system and the normal immune surveillance system and the entire body. Also, oncologists tend to be people who are attracted to huge volumes of knowledge because the cancer affects all the parts of the body. So you have to be a pretty good nephrologist, pretty good infectious disease, and so on down the list. And that really keeps you sharp and on the cutting edge. The research also tends to be very fast, and it's like watching Disney. Dreams come true. It takes a decade or two, but we were talking about the concept of a monoclonal antibody and giving a Nobel Prize in 1975, and now there's a few hundred of them on the market, from everything from rheumatoid arthritis and inflammatory bowel disease to numerous types of malignancies. And there are other examples. We were talking about cells of the immune system when we discovered there were cells that were like Marines, which would be the cells that you would find in something that was acutely infected, and you saw it as just an infected area, pustule. Those are like the Marines, the neutrophils, the cells that hit the beach first. We learned about them, and then we learned about a whole different family called the lymphocytes. Very smart cells. Well, then we realized there were two different kinds. One made these grenades called antibodies and would throw them at specific bad guys, and the others were the real brains, and they were the T cells, because they got programmed early on in life when they ran through the thymus gland in the neck. And now a dream was these killer T cells, because that's what they do, if we can gin them up, if we can really get them, frankly, pissed off at a specific cancer foreign aspect that the cancer cell has, but normal cells don't. These so-called CART cells are now being reported right now, today, at the American Society of Hematology, of causing remissions in acute lymphoblastic leukemia that have never been seen before. And soon they'll be commercially available and the techniques will be available. So the speed is phenomenal. And I knew it was a field that it would do that. By the biotechnology aspect would be enormous. There was no chance to make a lot of money because I was on active duty. So although I was there with the first team to make the first human monoclonal antibody, and the reason why that's important is because if you give one dose of the typical early antibodies, you get anti-mouse antibodies from that, because it's like a vaccine, but it's a vaccine made from an animal, and you make a reaction to that animal. We were able to develop at Scripps and Salk and UC San Diego the humanized version, and it took off. The field just took off, but not with me financially. I just continued on my active duty career, and the joy of watching it just fly, just absolutely fly. And now we have Amgen and IDEC and Celgene and so many products. So that's all very exciting. That's one aspect. That's the science. The other side is the people. When people are afraid, you can see courageous things. You can see things we recognize clearly as fear, but they know what they're afraid of. When people are anxious, they don't know what it is. It's the same feelings, but it's worse. It's fear of the unknown. And fear of the unknown is like sucking parts of your soul and slicing your psyche. It is devastating. And to be able to enter into that anxiety of these patients who don't know what it is that is about to occur, and there's so much in oncology that they could know, and they could be a co-captain of their ship, as it has been said, that the chance to be part of that puts you so close to the human spirit, so close to the human soul, so close to what it is to be human, to be a divine vessel. That's what I believe. There's nothing else like it. In orthopedics, you slam, a hip into somebody, walk away, here's some pain pills, and it's over. Now I'll get letters from orthopods, but you know what I'm saying. But in oncology, there's, if you want to, there's a chance to be the parish priest, or to be the spiritual guide or listener, to be the friend, the comforter, the counselor, the informer, the co-collaborator, the team builder, the co-captain, the confidant. All of these roles are present to you, and the guide, when major decisions occur, the guide, but not the one that says you must do this, because patient autonomy, one of the first sections of my book, always comes first. So you must educate them, and thus the book.
Okay, now, so wait, let's talk about, you said that operative word, you must be educated. You must educate them. You wrote the book to educate. So we're in a time where everybody has their PhD from WebMD. And sometimes it's quite difficult because everybody believes that they have as much expertise as doctors who have years and years and years of training and experience on real live people and know the research and know how to get results. So you say what about these PhDs in WebMD?
Well, it's a great risk is what I say. It's as if you were to say, I own a Ford. Well, all right, go find it in the world's largest Ford parking lot at the Ford factory in Dearborn, Michigan, for example. You can't. All right, I own a Ford and I tell you the make and model. Well, there's thousands of them. You still can't. All right, I tell you the color. You still can't. You need the vehicle identification number. You need to be that specific. So when you're reading on the web and consulting Dr. Google, you're not consulting about you. You're consulting about broad brushes of a particular disease at best, but you're not consulting about the details of you. And you are feeding your anxiety. You are usually making it worse. However, directed to good sites and to good, for instance, clinical trials and to the NIH and the National Cancer Institute, once you're in the loving arms of your oncology team, then it can be a great asset when used appropriately, but it's not an asset when it's the first thing that you do, or go rushing out to smoke the latest whatever, or take Uncle Joe's Kickapoo Joy Juice. I mean, whatever, you know. You end up with people, 40% of people, and we think it's at least a $50 billion industry, look into complementary and alternative medicine before and or during their care for their cancer. And doctors need to know this because these things can interact. And there are very effective therapies, as well as there are times when there is no effective therapy. So you try to help guide them then with the best things that won't hurt them, that might give them at least a placebo effect, and God willing, perhaps something more.
So wait, let's talk again about Uncle Joe's Kickapoo Joy Juice. And you spoke about complementary and alternative medicine. Now, having switched my career into functional medicine and doing with homeopathy, I've gotten training in helping people with cancer. I always tell people it's not either or, it's both. And you need to partner with people who really do know something. And so I've been to conferences where there's a lot of research on treatments that work for people in conjunction with other treatments. There are types of treatments that work when there's been failure of everything that's out there on the market. And I associate with doctors who get phenomenal results, especially in those people who have no other hope in anything else, but also in supporting people in their nutritional status with things like IV nutritional therapy while they're going through this, so that they end up doing maybe better than somebody who does nothing at all. And so how do you tell people to partner with the right, not Uncle Joe, but with a practitioner who has some background and training? Because I mean, I have information on very specific protocols, very specific stuff that works and doesn't work, and things that are just downright stupid, and others that, oh my gosh, you know, that IB curcumin, you know, there's thousands of studies on that, and it works in this, that, and the other thing, and here's the results of it. So how do you tell people to find qualified practitioners to help them with the complementary and alternative therapies?
Well, three things. One is to remember that anecdote is not synonymous nor spelled the same as antidote. The majority, wishing to offend no one, including yourself, of what's out there is not, point number two, an appropriately done controlled clinical trial with biases removed, placebo included, standard of care being involved, replicated by independent third parties, approved by institutional review boards, and then editorial review, and published in peer-reviewed journals, and of course replicated. The vast majority doesn't mean it isn't true, but it does mean that you can't say it. Then we have statistical significance, meaning if I take a coin and I flip it a penny, and let's just presume that if we cut a penny directly in half, that the weight on one side equals the weight on the other side. Let's just make that presumption. If I flip a penny in the air and I get 6 heads in a row, well, and I asked people, what are the odds that I'm going to get another head? They were always 50-50. It's an anecdote that you saw 6 heads. The reality was it was always 50-50. The third part of what you asked, what do you do to find a practitioner? Well, you become informed, and you let the patient, once you've brought them into standard allopathic medicine and being honest with yourself as to what is and is not available, you really do have to be informed. And fortunately now the National Cancer Institute does have a superb site for complementary and alternative medicine, and they don't point fingers. They don't humiliate. They don't poo-poo. They report on this is what we know so far. And the FDA has come a long way also with this is what we know so far, and we don't know. We can't make a statement one way or the other. You also mentioned if a patient is terminal. You didn't use that word, but where the standard other forms of care are reasonably not available. First of all, you question whether that's true by searching the web, the physician should, for trials that are out there to be sure that for your patient, they do or do not fit a trial, both logistically, where they physically are, and can they afford it, and where are they going, and will it be approved, and so on, in addition to physically, based on their performance status, how healthy they are, what type of tumor, where is the tumor, how good are their blood values. So you do that work to be sure that when you say, this is what's out there from a thorough search of the literature, which the internet is a godsend, and you can do, and oncologists can do that very quickly, you can then say, all right, I have nothing more. I have these things that I can do that can make you feel better. And I also have hospice, which has a beautiful role to play, social workers, I have support groups, but I don't personally have myself a practitioner's basis as complementary and alternative medicine. I can't tell you that anything has been shown, for example, to cure with statistical significant results pancreatic cancer, for example, metastatic colon cancer, metastatic lung cancer. Are there anecdotes? Absolutely. Is there hard data? Absolutely not. But let's give a different example. Let's look at...
Let me just ask a difference about this, the hard data, because one of the difficulties in complementary and alternative is there's just not funding for it a lot of times. So it's very difficult to do these large studies. And there's people who look into it and stuff. I mean, very scientific. I've been to places where, you know, there's science going on to the best of the ability, but the type of studies that are funded by the government and drug companies, where they're going to sell it on the stock market or whatever, it's just not there for certain types of complementary and alternative therapies. So therefore, I don't know if we're ever going to get there with that rigor that we get there with a particular drug, because you know, just that's not the slant of where we're going right now in this country.
That's the point well made.
That how do people identify something reasonable once they have stage 4 lung cancer? And I have a relative that has stage 4 lung cancer, was told, you have a very rare type and there's nothing that you can do. And I'm just like, well, I understand you've gone for trials and they've decided nothing's appropriate for you. I'm like, you know, here's the point where you really need to consider something else. And the people that I see to get miracles when they've been told there's nothing else are people who try these other things. So now, before, I never said anything to her. Now, I've been knowing this has been going on for a couple of years, but I never suggested anything until she shared. They said, I have this rare gene and it's stage 4. And I was thinking about managing or trying to do this, that, and the other thing, but I just said, forget it. And I said, there are some other options out there for you. And here are people that I know who work in this area particularly. I don't guarantee your results, but I've seen people that have anecdotally, because it's not going to be a study, anecdotally have gotten some results. Whereas the traditional oncologist has said hospice, or, when people get angry when you say hospice, especially, my cousin's wife, she's 50. She's 50. You say hospice? I'm like, I'm mad you said hospice. So what does somebody like that do?
Well, they have to be counseled well by an open-minded oncologist that we don't know everything. That's the first thing. And that's very important. And that's not very common. But it should be. It should be. They also need to be told that many of the drugs that we have, not just in oncology, but in the pharmacopoeia, the group of drugs that we use to treat human diseases, come from the plant and animal kingdom and found their origin in the plant and animal kingdom. Some were synthesized by rational drug design, looking at corollaries in the plant and animal kingdom. So could there be other things out there? Well, not only could there be, there most certainly are, but we haven't stumbled on all of them. Yes. The patient's autonomy is the second point. In 1896, back in the days when MD meant magnificent demagogue, the Supreme Court said, no more of that. The patient is co-captain of the ship. The patient is in charge of their own body. And the oncologist needs to have that discussion, and usually doesn't. And they need to have that discussion with the patient that you're in charge here of these kinds of decisions. And I already mentioned how the oncologist should be aware in their regional area, in their geographic area, if there are others out there. It's equally incumbent upon that oncologist to know what has been proven to hurt people. There's two ways they can be hurt. One is psychosocially, where expectations are raised. There's little understanding of the placebo effect. You'll get 12 to 13% response if you give people just water intravenously. And that's neurolinguistic programming, and that's based on neurochemicals that are telling us that we believe that we're getting an active drug, and those that believe that actually, about 12% of the time, feel better. It's not that their tumors remit. And you want these people to be avoiding things that are known to hurt, to cause harm, that have been seen to do bad things.
For example, what can you give us some that you know?
Laetrile. Let's use a popular one from the past, Laetrile.
Okay.
Laetrile had cyanide in it. Then we have vitamin C. Linus Pauling wins 2 Nobel Prizes and 1 Dummy of the Year award when he talked about megadoses of vitamin C. Well, vitamin C, although it's a water-soluble vitamin, which means it is dissolvable in water. I know you know this, but for our listening audience, nonetheless will crystallize inside the kidney tubules and the kidney structures and other parts of the body if it's given in the doses that he recommended. And finally, the trials were done, and they said, this hurts people. This not only doesn't help, this hurts people. Those are 2 famous examples. Another one, marijuana.
Oh, yay. That's what I was going to ask you next. Go ahead with the marijuana.
Is different. It's different than THC, and THC is different than the individual cannabinoids. When we speak of marijuana, we need to understand amongst us, what are we talking about? If we're talking about smoking a joint or doing a doobie or, hitting the bong, well, that's inhaled foreign substances and generally not a good idea out of the gate. It's usually not good to be inhaling that much particulate matter. But there isn't a lot of data that suggests that doing so causes lung cancer or pulmonary lung disease. There just isn't a lot. And there's also the issue of purity. You don't know what it is that you're getting. You also don't know the concentration. Back in the 70s, it was around.
Let's back up. Let me back up a little bit, because there are many states, or enough states right now, that have made marijuana legal, and enough that everybody in the country can now get there pretty easily to get it illegal. And they have these medicinal dispensaries, and you can get gummy bears and brownies and cookies and just all kinds of stuff. It's evolved. And I've heard anecdotally people talking about decreases in pain, decreases in nausea, decreases in their anxiety level from using these type of preparations. Talk a little bit about that.
Sure.
What's going on?
I'm actually going to be interviewed by another radio station on marijuana, so it's a perfect topic, very timely for me. This is what we have. Back in the 70s, the concentration was about 3.5% of tetrahydrocannabinol, or 9-delta THC. That's a lot of scientific language for saying the most psychoactive substance that's in there, which turns out not to be necessarily the most active substance for the amelioration or the improvement of treatment of various symptoms, by the way. So the FDA looked at data through the late 70s and early 80s, and trials began. And out of the more than a dozen cannabinoids, cousins and friends and incestually related compounds that are found in pot, they came out with the drug Marinol. And Marinol is an approved drug for the treatment of chemotherapy-related nausea and or vomiting when other therapies do not work. Now, here's what the data says regarding it. And hear me out, because there's kind of good news for the marijuana people at the end. It does not work as well as the drugs that we have. It doesn't. If it does for an individual, then it does for that individual, and that's a great thing. But it does not, in any trial ever, has been shown to work as well. It works, but not as well. However, it may be one-stop shopping, where one drug is giving you anti-anxiety, a sense of euphoria, an increased appetite leading to weight gain, decreased nausea, and decreased vomiting, rather than 5 drugs that individually can do that better compared to one drug that doesn't do it as well, but might do it. So my recommendation is to, again, oncologists, know the literature regarding marijuana and understand another point, which is the purity and the potency is not necessarily regulated in every state. It's what that vendor claims. You remember Maui Wowie, or, Panama Red, or whatever, from the 70s. And they say this has this potency, they don't know that. They haven't done high pressure liquid chromatography. They're not going to pay the money to do that. But we do know through continual cultivation and breeding of these cultivars, these plants that come from constant application of agricultural principles, they're far more potent. So you see that people who have used it before tend to not have adverse reactions and have a positive response in just about every survey. And you see people who have not used it before have a slightly greater chance of seizures, psychosis, dysphoria, and hallucinations.
So
it's very bad.
So what does that mean? Does that mean that
you warn the patient who's never seen it before, and you hope and pray that the person who's vending it, in some states, such as Colorado, they actually do want to look at the purity and have them marked as to the potency. You start them very low. You don't use something that is oral if they can take it by another means, because oral is very rapidly absorbed and very highly potent, which is very interesting. It's usually not the case. And you see in a friendly environment, how did they do when nothing else is working? you also embrace it early on with them with, I apologize, that phone's supposed to be off. You embrace it with them early on that I am open to the use, now in California, to the use of this in our armamentarium. I have drugs for nausea and vomiting that taste good and work phenomenally. Zofran, ondansetron, works great, which is a drug that I was a principal investigator on and helped develop. It's a phenomenal drug, but it doesn't also add the euphoria and the weight gain and the increased appetite. It doesn't give you all of this nonstop shopping. So you have to have an open mind that this particular drug, Marinol, and smoking pot can, in some people, have a positive outcome that leads, and a positive outcome is going to lead to higher quality of life, and it's going to lead to possibly longer survival, definitely an increased sense of control, which is hugely important to the human psyche and soul, and occasional overdoses on Oreos and peanut butter.
Well, I'm not taking that then. I would be the person to have the psychosis because I've never smoked marijuana or done anything with it. All my friends are, and I'm not doing it. So, but I just would be the bad. I'm open to it. I have people want to argue me down. It's the best thing that ever happened. I'm just like, wait. There's more to be said about it. I'm not opposed to it, but wait. So I really appreciate that extensive explanation about marijuana use for medicinal purposes. And now we know, for those of you who've done it before, it's more likely to have a positive beneficial effect in how you feel. Your quality of life will be enhanced. And of course, when we have people who have any type of disease, we want them to have a better quality of life. So I just want to say, when tumor is the rumor and cancer is the answer, Dr. Kevin Ryan, thank you so much for your time, for your service to our country, for your service to people who are in a crunch with cancer and don't know what to do. First as a clinician, but also now as an author to help them navigate the system. So thank you so much for the interview, Dr. Kevin Ryan.
It's been a real pleasure. I do want to add that this is nonprofit. I've paid for all the production of the book myself. It's my way of saying thank you to the folks who came in and laid their life and their fears in my hands and said, help me. And this is a good way to try and help them, to get this message out that there is a book that walks them through all the aspects of oncology and what could happen to them, so that they are not in the dark. Right up front, they can be exceedingly knowledgeable and know where to go and what to read in addition to the book. So if just for a moment, I can tell you, you asked why I got started. One was that I diagnosed a melanoma on my arm in my first year of oncology fellowship. That was very humbling because no one gave me comfort. No one put their arm around me. And then the Chief Master Sergeant of the Navy, which is the god of the Navy and the enlisted ranks, was dying of multiple myeloma. I would go to him on rounds at the last patient, bring the students with me because he was a guru and I was the little grasshopper. And he would teach me about the world. And he said to me 30 some odd years ago, you shall write a book and you will write for us. You will tell us all the things we are never told and that we don't know. And you'll do it right when you're ready to retire. This you will do for me. And I'll never forget him. I'll never forget him. Wonderful man. And that's...
Well, thank you so much. I really appreciate your time and your service. When tumor is the rumor and cancer is the answer, Dr. Kevin Ryan. I'm Dr. Veronica, the Wellness Revolution.
Thanks, Dr. Veronica.
Thank you for listening to the Wellness Revolution podcast. If you want to hear more on how to bring wellness into your life, visit drveronica.com. See you all next week. Take care.